In this next section, we will review the mechanics of mechanical ventilation, including peak and plateau pressure assessment and interpretation, calculation of airways resistance and respiratory system compliance. We will review the concept of flow rates, patient ventilator dyssynchrony, and auto-PEEP. So what exactly are peak and plateau pressures? It is generally easy to understand the concept of peak pressures. For the intubated patient, their end expiratory pressure would be that pressure when they're neither inspiring nor expiring. As the machine pushes in a breath, it will take a certain peak or maximum amount of pressure to deliver that tidal volume through the ET tubing, through the patient's airways, and to expand their lungs. The peak pressure is clearly demarcated as the highest pressure required to deliver a given tidal volume. Normally, breaths are delivered and the patient exhales. A breath is delivered and the patient exhales. However, it is possible to implement within a respiratory cycle what is called an inspiratory pause, such that now the breath will be delivered, but rather than letting the patient exhale, the expiratory tubing returning to the ventilator is transiently clamped, such that the breath is trapped within the site within the patient. So the breath would be delivered, but rather than being allowed to exhale, it is held in for the length of the inspiratory pressure, and then the patient exhales. Breath is delivered, and then it's held in, and then the patient exhales. Graphically, one can see that this pressure looks like a plateau, and hence is called a plateau pressure. It is also called an inspiratory pause pressure, since it is that pressure identified while an inspiratory pause is being delivered. In this picture, one can see that a volume of gas is being delivered intermittently by the machine. While the breath is being delivered, inspiratory flow occurs, but instead of immediately leading to expiratory flow, an inspiratory hold or an inspiratory pause has been instituted, such that the breath is delivered and held in for a period of time before the patient is allowed to exhale. Airway pressure show that as the breath is delivered, peak pressure is reached, which drops to a plateau pressure, and then which drops to the PEEP level once the patient is allowed to exhale. The peak inspiratory pressure is that pressure necessary to get a tidal volume of gas into the patient, which depends upon a number of factors, including how big the volume of gas is being delivered, the patient's lung respiratory system compliance and airways resistance, as well as the flow rate at which the breath is being delivered, and whether or not the patient is starting with any given level of PEEP. When one implements a plateau pressure, the overall peak inspiratory pressure can be compartmentalized into that pressure necessary to overcome airways resistance, as well as that pressure necessary to overcome lung and respiratory system elastance. The peak and plateau pressures allow the physician to calculate both an airways resistance and a lung compliance. Airways resistance is equal to the peak minus the plateau pressures divided by the inspiratory flow rate. Inspiratory flow rate is typically assessed in liters per second and is most commonly set at 1 liter per second. This can be adjusted and must be included in the equation if that is the case. However, typically with a 1 liter per second flow rate, the airways resistance calculation can simply be reduced to the peak minus the plateau pressures. Normally, the difference between peak pressure and plateau pressure is low, less than 10 centimeters of water per liter per second. Higher values for airways resistance imply a number of possibilities, including perhaps simply a narrowed or small ET tube, but could also represent pathology within the airways. Compliance is delta V over delta P, or the tidal volume in cc's divided by the plateau pressure minus PEEP. Normally, static compliance is greater than 60. When static compliance is less than 20, it implies that the patient's respiratory system is so stiff that it is highly unlikely they would be strong enough to sustain ventilation independently. In terms of pattern recognition, Patients who have an increased peak pressure but a normal plateau pressure clearly have increased airways resistance, which could be due to endotracheal tube abnormalities, such as a small endotracheal tube, a plugged endotracheal tube, or an endotracheal tube which is being bit by the patient who needs more sedation or a bite block. One could also have the same pattern in patients who have bronchospasm. Hence, if you see a patient with increased peak pressures, one should check the plateau. And if the primary problem is one of increased airways resistance, one should assess the endotracheal tube by passing a suction catheter through it to see if it passes easily. If it does pass easily, that implies that the increased airways resistance is due to bronchospasm and the patient should receive bronchodilators. Conversely, if the peak pressure and the plateau pressure are both elevated, it implies decreased respiratory system compliance, which could be due to a number of processes, including ARDS, pulmonary fibrosis, the development of a pneumothorax, large effusions, ascites, etc. In this setting, one should check a chest X-ray to see which of these processes is present. Elevated pressures in the airways and in the alveoli can lead to barotrauma. Barotrauma is manifested by pneumothoraces. Barotrauma is manifested by pneumomediastinum, and barotrauma is manifested by interstitial pulmonary emphysema with the development of pneumococcus and damage to the lung parenchyma itself. In order to avoid the development of barotrauma, we try to keep the peak pressure less than 45 and the plateau pressure less than 32. Flow rates are not typically set by the physician, but can be adjusted. Normal flow rates typically are about 1 liter per second or 60 liters per minute. When flow rates are abnormal, it can lead to patient discomfort. If the flow rate is too low, the patient will sense air hunger and will be trying to inspire throughout the delivery of the breath by the machine, leading to excessive work of breathing. If the flow rate is too high, it will lead to the sudden quick delivery of a breath, which could increase the risk of barotrauma, could lead to tachypnea and double triggering, and can lead to alarms on the ventilator. Both can be adjusted up or down depending upon the clinical scenario. As one can see in this diagram of a constant flow where a breath is delivered, and that breath is delivered at a constant flow rate until it's completely delivered, and then the patient is allowed to exhale, one can see that the pressure rises linearly or often in a somewhat concave up pattern until that tidal volume has been delivered. One can adjust the flow rate by changing the flow profile from the so-called square wave to a decelerating flow rate profile or a sinusoidal flow rate profile. In both of these circumstances, the length of time necessary to deliver the breath is lengthened. As you can see here, it takes longer to deliver the breath since the average flow rate is lower. This leads to the possibility that during expiratory flow, the entire breath may not have been exhaled before delivery of the next breath, which could lead to the possibility of auto-PEEP. In all cases, the same tidal volume is being delivered, but by different flow profiles, leading to differences in inspiratory time. Why would anyone ever adjust from one flow profile to another? In truth, there are not many indications. By changing from a constant square wave flow profile to a decelerating flow profile, one can see that the peak pressure is reduced. And while that may be a good thing in some patients, it leads to the possibility of the development of auto-PEEP, which could be disastrous for other patients. One would consider reducing the flow rate if the primary problem is one of excessive peak pressures. One would consider increasing the flow rate if the problem is that there's inadequate time for exhalation, leading to the development of auto-PEEP. On the left, we have a short inspiratory time and long expiratory time. The breath is pushed in quickly, leading to high peak pressures, and the machine will alarm. On the right, Inspiratory time has been lengthened by switching to a descending ramp flow profile. In so doing, the peak pressure has been reduced. However, as inspiration has been lengthened, expiration has been shortened, allowing an inadequate time for exhalation. And as one can see here, the last breath has not been exhaled completely before the next breath is being delivered, hence the possible development of auto-PEEP. In terms of flow rates, one should consider adjusting the flow rate in order to reduce peak pressures, to address unexplained tachypnea, or to improve patient comfort, as well as to try to minimize the risk of auto-PEEP. To summarize, increasing flow rates will reduce auto-PEEP but increase the peak pressure. Decreasing the flow rate will reduce the peak pressures but increases the risk of auto-PEEP. The newer mechanical ventilations allow a real-time evaluation of a number of parameters, including tidal volume being delivered, flow rates, inspiratory and expiratory, as well as airway pressure. This graph illustrates on the left a square wave delivery of a set tidal volume with a steady increase in airway pressure. The middle cycle, with similar parameters, shows that the airway pressure does not rise linearly, but instead is scalloped before reaching a normal peak pressure. On the right, this is exaggerated even further, in that despite the fact that the machine is pushing air into the patient, airway pressure is actually declining, indicating that the patient is breathing in excessively to drop the airway pressure lower than baseline. The middle and right flow profiles would be indication that the patient is demonstrating excessive work of breathing. The patient must be breathing in while the machine is pushing the breath in. If the patient is breathing in during inspiration when they should be relaxing, it's an indication that the patient is unsatisfied with either the size of the tidal volume or the flow rate of the tidal volume. When one sees scalloping of the inspiratory flow profile, one should assess the patient to see if they are agitated, to see if they require a higher tidal volume, or to see if they require a higher flow rate. These quotes summarize evaluation of airway pressure waveforms from Dr. Charlie Alex of Loyola Medical Center. During true relaxed or passive inflation, the airway pressure tracing shows a smooth rise, it remains convex upward, and it is highly reproducible from breath to breath. In a patient who is receiving partial or inadequate ventilatory support, the degree of deformation and scooping of the airway pressure provides a means of monitoring the amount of effort expended by the patient. Assessing auto-PEEP can be challenging, but one may identify a clue as to the presence of auto-PEEP by looking at the flow waveform. Inspiratory flow is positive, expiratory flow is negative. If the patient has exhaled the entire preceding tidal volume, flow rate should cease. In cases where the expiratory flow does not come back to baseline, it implies that the next breath is being delivered before the last breath has been fully exhaled, clearly creating the possibility of auto-PEEP. It should be recognized that many patients are placed on continuous nebulized bronchodilator therapy. If that is the case, the continuous nebulization may lead to ongoing expiratory flow without the development of actual auto-PEEP. Another way of illustrating this, we have inspiratory flow, and we would like to have full expiratory flow back to baseline. However, in some patients, you may have inspiratory flow and expiratory flow that is quite delayed, leading to air trapping and auto-PEEP. To measure auto-PEEP, one has to apply an expiratory hold. Remember that in assessing plateau pressures, we applied an inspiratory hold, and that during inspiration, the valves were clamped, and an inspiratory plateau pressure was assessed while the tidal volume was within the patient. In an expiratory hold, the patient is allowed to exhale for a set period of time during which time one would anticipate the entire preceding breath to have been exhaled. At that point, both limbs of the circuit are clamped, allowing an assessment of whether any pressure was still remaining within the patient. So we have inspiratory flow and expiratory flow. Here we have inspiratory pressure, which comes back down to the PEEP level, but when one clamps the expiratory limb of the ventilatory circuit, any trapped gas would continue to be exhaled into the circuit, raising the pressure in the circuit, and identified as PEEP. In this diagram, we would call this auto-PEEP, since it developed intrinsically.